questions to both the speakers will be. Sir?
Oh, it's finished?
Can be asked.
There's one more talk.
Dr. Vijayakumar, use of glargine in pregnancy.
As of now, we don't use it. It has not been recommended. So probably there are been trials, but that it has not come into recommendation. So it has been used, but still cannot be. This forum has given as a guideline that it can be used.
But I think Professor Sundaram will know, when they are already on Lantus, like a known diabetic passing through, they can continue with it. Passing through pregnancy.
Yeah, somebody.
Is there any old medications that is suitable? Is there any oral OHs that will be suitable in pregnancy?
So far, we cannot initiate. Insulin is the drug of choice as far as Indian guidelines.
As far as insulin goes, it's only glargine. As far as insulin goes, is it only glargine or any?
No, glargine is not approved for use in pregnancy. The other insulins are aspart, Lispro, short-acting analogs, and all human insulin we use. They can be used, and in the long-acting detamir is approved.
Why not glargine?
Glargine, it is not approved. Whatever is approved, only we can use it. It is not adequately tested.
Is there any reason behind it?
Not been used. Not approved.
But off-label usage is there. Off-label usage. We still use it in among patients who require high dose of insulin. Off-label. OHA, metformin can be used in pregnancy. Till trial in PCOS, we continue till the end.
It's a nice presentation there, sir. I would like to know if there's when a high dosage of basal insulin is required, do you recommend using the basal insulin twice a day based on the pharmacokinetics and dynamics? And what does that extrapolate to the U300 also?
Yeah, when the determic came and also even the Landers, the dose is above 40 units, they recommend that you can split the two doses because it overlaps better. You're right. The better than that is that if the sugar is pretty high, you must know that basal insulin is recommended as the first line of insulin initiation mostly in the Western countries. But unfortunately, we in India probably may still require even a short-acting insulin because we always start insulin pretty late. The average HbA1c of starting insulin here is almost 9.4, 9.7. Therefore, it's not only the fasting, even the postprandial is also pretty high. So you may need basal plus. But answering your question again, that if when the Landers came and when they were when the dose was above 40 units, there was a recommendation that you can split into two doses. Even the new one, which is known as Risodac, which is actually more than 36 hours acting, which is a combination of short-acting insulin and a long-acting insulin, we use 2 times because the short-acting you want to have both the times, and it doesn't matter because it just goes away in the urine. We do not know about U300. Nobody has used that. The other thing is that U300 does not come in a premixed one in any way, in any case. It's only the Trashiba comes because of the pH advantage. So U300, you have to always use it with, again, basal plus or basal. Oh yeah, sure.
The pain is more. That is why you give lesser volume, U300. The advantage is that injection site pain is less. No, I don't think. As of now, U300 you don't split.
We had, in origin trial, we had patients who were taking about 200 units short, very obese people, yeah, very obese guys, yeah. What did you say? Stacking?
Stacking of insulin.
Oh, no stacking. Yeah, maybe it's the same thing according to the U300. None of them have stacking effect. We're not seeing that happening. I mean, we have actually given much higher doses, even with U300 as well as Tresiba. Doses are pretty high. One good thing about all basal analogs are you can use pretty high doses of insulin without the risk of hypoglycemia in order to actually achieve a good fasting plasma glucose. But of course, the cost goes up. That's the only disadvantage that we have.
Now, with the advent of incretin-based therapies, I think you can always add on drugs which will also reduce the doses of insulin. So probably the kind of, dosage that we are now talking probably can be addressed with a combination. So you require a very smart prescription writing, so that will reduce the weight gain as well as hypoglycemia.
For whom? Yeah, it is. For any patients other than pregnancy is acceptable. And gliptin. And gliptin. Other than.
Also studies that gliptin reduces the dose of insulin.
Sir, for type 1 diabetes, can you use U300? Age limit is not there, like age is not related to that. Above, like Clargens. Thank you, sir. If no questions.
Last question, sir. Modify the dose. You can come to the mic, sir.
Okay.
Duration of action is long, 26 hours, 40 hours. And if there is no peak, it's a flat action. Is there any significance to the time of administration? Can you give it in the night or in the morning?
Yeah, it's pretty flexible. You're right. In fact, there's a flexi study done by Degludac where they said whether you take it in the morning or in the evening doesn't matter at all. But usually the recommendation is not that you change it. Usually there's a 2-hour window where you can take it. Even if you, because it is almost 36 to 40 hours, even if, and if your diabetes is under good control with a fixed dose of either U300 or you miss even a single day, sugar will not go out of control. And if you take it today morning and tomorrow morning you forgot, you can take it tomorrow evening, no problem. Correct. That's a flexibility is one advantage of the long-acting insulin analogs.
Thank you, sir. Thank you, Dr. Ramachandran and Vijayakumar.